medicine 3. We had been referred to, like, there is a primary in general ANC visit. She showed serial drop in hemoglobin. There was no improvement in hemoglobin with IV iron correction as well. And further monitoring shows anemia with thrombocytopenia. And the patient was referred in view of further management. She was asymptomatic all this while, except for exertional breathlessness and etc. But she didn't complain of it. She thought it is normal with pregnancy. Only with the serial monitoring in this government hospital, they found out there is drop in HB and thrombocytopenia, which developed subsequently. And outside investigation showed hemoglobin of 6.3 grams per cent, and RBC was 1.5 million per cubic millimeter. Platelet was 61,000. MCV is 126. Serum iron was low, and TIBC was 419. USG abdomen and pelvis showed left dysplastic kidney, and she was treated outside with 2 PRBC, 8 iron sucrose, and 1 dose of vitamin B12. So at 28 weeks of gestation with antenatal, first the patient went to OG side, and after that she was referred to OMC, telling that the patient 28 plus 3 weeks of gestation with antenatal risk factor of short stature. So for further evaluation, the patient was admitted on OMC side. On asking the history, she had no history of fever, rheumatological symptoms, no weight loss, no loss of appetite, no significant drug history, no addictive habits, and no significant family history as well. Pulse rate 120 beats per minute. BP was 100/60. Pallor was present. No icterus, clubbing, cyanosis, lymph nodes. Abdomen showed no hepatosplenomegaly, and there was flow murmur secondary to anemia, and there was bilateral vesicular breath sounds were heard, but there was no added sounds, and CNS was fine. Basically, she was not in failure, and HB was 9.3, RBC is 2.69, and the total count was 6,400. MCV is again 104. Outside also it was 124. Here it is 104. MCH is 34.6, MCHC is 33.1, RDWC is 21.7, and hematocrit is 28.1. She's basically looking like a macrocytic anemia. And we considered the differentials of nutritional, which could be combined iron and vitamin B12 deficiency, which is more common in Indian setup, and megaloblastic anemia, because there was macrocytic picture, SLE, hypersplenism, leukemic leukemias, and myelodysplastic syndrome, and aplastic anemia. In this setting, it is pregnancy. Usually they come up with nutritional deficiencies, yes, but outside she was treated again. Nutritional is still in our mind, but we thought it is better to think of other conditions also, because serially she's dropping, the HB is dropping, the platelet is dropping, and the megaloblastic anemia part, we'll have to further investigations are needed. And SLE, because she is a young female who's 22 years old, so we wanted to keep SLE in mind. Bicytopenia is there. Hypersplenism, unlikely with the USG showing no spleen. But still, again, we wanted to no splenomegaly outside USG, sir. Here USG is yet to be done. Okay. So we didn't. We wanted to rule out in our setup. And leukemic leukemia, that is basically for infiltrative disorders secondary to malignancies, and myelodysplastic syndrome and aplastic anemia. So LFT.
Maybe I didn't get the sequence. So outside treatment was when, and you said there are 2 times she had sort of.
The thing is, she's a primary who's been regular ANC visit in the government hospital, sir. So that time they saw there was this HB drop, there was this platelet which is dropping in spite of giving iron correction, in spite of 2 RBCs which is transfused, and 1 dose of vitamin B12 is given. So when it is not responding, they tend to think of other things. So they want
the interval. When was the initial injections for B12? That was just
before coming here. She took they gave 2 transfusions of PRBC and vitamin B12 simultaneously. Just before coming here. And then we'll go with the our hospital investigation. So LFT is it is within normal limit. So in megaloblastic anemia, ideally this this indirect, there'll be mild indirect hyperbilirubinemia, and this LDH will be elevated because there'll be intra-marrow hemolysis will be there. So that is not there. So megaloblastic anemia is unlikely, and vitamin B12 is also given outside, and we are going to B12 level is also 1,800 here, and folic acid is 19.8, and creat is 0.5, retic count is 1.65, but reticulocyte production index is 0.77. ANA is negative, C3, C4 is fine, dsDNA is negative. So we basically rule out SLE here. HIV, HBsAg, HCV is negative and malaria is also negative. Because the reticulocyte production index is 0.77.
Just 1 minute. You've just received some replacements for B12 and you've got some transfusion.
Yes.
How would you interpret B12 levels in this situation?
So one she's received B12 and folic acid also should have been treated in the first trimester. But the thing is, LFT is there. So one, to rule out vitamin B12 deficiency, there will be ineffective bone marrow erythropoiesis that will be going on. That will lead to a slight indirect hyperbilirubinemia. LDH it will be like a slight hemolytic pictures will be there, but that is not there in this case. So that is how we rule it.
So you mean to say?
Yeah, it is all evidence together. Yeah.
No. The LFT, what are you trying to highlight? I didn't understand.
So in megaloblastic anemia, there will be ineffective marrow erythropoiesis that will be going on. So this, the improperly produced cells will undergo lysis in the marrow. So that will give a slight hemolytic picture. That is not seen here. So with the collective LFT, vitamin B12, folic acid, it is unlikely. That is what we were thinking of. Yeah. And yeah. 2D echo, here it was normal except for trace TR was there, and then USG abdomen and pelvis showed right dysplastic kidney. There was no hepatosplenomegaly. So we ruled out tropical splenomegaly here. And then because of this reticulocyte production index is 0.77, and we had to rule out this leukemic leukemia, aplastic anemia, myelodysplastic syndrome, we had to definitely get one bone marrow done. So we got this bone marrow, which showed markedly hypocellular smear, aplastic marrow. Trophine biopsy is also showing less than 5% cellularity. Aplastic marrow cannot be excluded. This is the bone marrow report. So with this, now the aplastic anemia comes into the picture. So for this aplastic anemia, we had to get all these investigations done it is the this is a series of investigation which is needed for aplastic anemia workup. So this full blood count, which is already done, reticulocyte count, blood film examination. Usually in aplastic anemia, you see this normocytic normochromic anemia, but in stress erythropoiesis, like pregnancy, they can have this macrocytosis as well. There are in Medscape, it is mentioned, it can still be present. And peripheral blood chromosomal breakage study, flow cytometry, vitamin B12 and folate level, liver function test, and other viral studies, and ANA, dsDNA is needed, because aplastic anemia is generally it is a disease of exclusion. So this vitamin B12 and folate is normal here. Liver function test is normal. Other viral studies like HIV, HBsAg, HCV is negative. And hepatitis A, it is like there will be acute presentation. She had no history of any jaundice or anything earlier. And CMV, it is if they are CMV and Epstein-Barr virus, you can get the titers positive in most of the individuals. So, and then ANA, dsDNA is negative. And then
there's something very odd about the diagnosis of aplastic anemia here. Can you see what is not fitting well? So that each of the 3 cell lines have a different lifespan, isn't it?
Yes, sir.
Your problems are happening more at the platelets level and also at the RBC level. Now, leukocytes have a very short lifespan. So in my understanding, your total count, leukocyte count is fairly okay, or did I get that wrong?
Oh yeah, leukocyte count is okay.
Why is that?
So most of the aplastic anemia, they don't present with pancytopenia. 60% present with bicytopenia.
Why is that?
That is depending on the it is the attack of the immune system against the cells, the hematopoietic cells. So usually most of the cases, this WBCs are spared.
Sure.
I have an article on that as well, sir.
No. I'm not. It's good to learn. So usually when I see aplastic, like in hematology and all that, the presentation, they have absolutely terrible leukocyte counts. So before we settle down as aplastic in a pregnant lady, which has a terrible prognosis,
yes,
I'm just wondering, have you thought through all the other things carefully? That's my intention. Yeah.
Yes, so we are trying to. So the criteria for aplastic anemia, one, the marrow cellularity should be less than 25%. Here it is 5%. And additional to that, you should have low platelet count. This is the criteria, sir. So, and or low neutrophil count or reticulocyte count should be less than 60 microliter, microliters, and very severe, it should be neutrophil should be less than 200, and non very severe, which is not fitting into any of this criteria. So this is a little easier version. So where there is absolute neutrophilic count is less than 500 and platelet count is less than 20,000 and reticulocyte count is less than 1%, along with bone marrow cellularity of less than 25%. So this is fitting into the criteria of aplastic anemia. Because not all the cell lines.
So her bone marrow looks terrible, but her ANC is okay. Her platelets are actually okay, not less than 20,000. And how much is her retics?
Retic is production index 0.77.
No, I don't know this much, but your production index is same as retics?
Usually we correct it to the...
That's a corrected retic?
Right, corrected
okay. So 0.67 or something.
0.77.
She doesn't satisfy that criteria.
Yeah, not exactly. But out.
No, keep things open. Just say the criteria is not met. We are still thinking in those lines, but it just doesn't nicely fit into the criteria. Okay.
Because the bone marrow, it was more of a plastic picture. We were like little having that.
No harm. Yeah. Just I'm saying that.
Sure. Yeah. So the key recommendation for inherited aplastic anemias, like comprehensive assessment should be performed, including family history, abdominal ultrasound, echocardiography, CT, and other extrahematopoietic abnormalities has to be ruled out. Cirrhosis, pulmonary fibrosis, renal anomalies. If all these things are present, then you will have to think in terms of constitutional rather than idiopathic bone marrow or bone marrow failure, which the evidence is 1B here. So we wanted to because this lady had short stature, dysplastic kidney, so we wanted to consider in terms of inherited bone marrow failure as well. And and we were also considering this hypocellular myelodysplastic syndrome. This hypocellular marrow-dysplastic syndrome, in bone marrow, there was no bone marrow blast, there was no ring sideroblast, there was no disc granulopoiesis, there was no disc megakaryopoiesis. So this we ruled out hypocellular MDS is being ruled out. And in the aplastic anemia workup, PNH screening for PNH is also important, but we had the financial constraint here, so we didn't want to get all the tests. Even though the PNH clone can be detected in 40% of the acquired aplastic anemia, the absence of PNH clone does not rule out immune mediated aplastic anemia. So, and the presence of PNH is not going to modify any treatment. So that is why we skipped this because of the financial constraint. And she was having more of short stature, dysplastic kidney. So there was this other features also, which was more pointing towards inherited bone marrow failure. So we wanted to get her chromosomal breakage study, which is sensitive to mitomycin C. And next generation sequencing of hematological disorder, which came positive for Fanconi anemia, and which is homozygous pattern, and it was autosomal recessive pattern of inheritance was present.
And just come back, very exciting. So just describe that test result. So sensitive to mitomycin C, what does that mean?
So this is Fanconi's anemia. It is a disorder where there is congenital DNA repair has been affected. So they, when you this chromosomal breakage study, when you do this, they'll have this typical patterns of breakage. The repair is because the repair is affected. When there'll be like when you go do this breakage study, they'll have this positive.
C is used as a inducer of chromosomal breakage.
Mitomycin C. There is one more IBD is also there.
Sure.
So
sure. Yeah. Okay. And tell us about NGS result.
Next generation sequencing, it is generally sent for general all hematological disorder. For hematological disorder, general this thing was sent. So it came positive, likely pathogenic deletion attributed to inherited bone marrow failure syndrome. Fanconi anemia was identified, and Fanca EX2130 deletion was found, which is it was a homozygous pattern. and autosomal recessive patterns also.
So tell us a bit more about that deletion.
So,
Is it like the commonest, or what is the cause of the illness? Are you coming to that?
so I
No,
don't
no, the deletion you have picked up.
So there are multiple deletions.
I know.
This thing.
Not that I know much, but in this, the natural course of this, how does it run itself?
So Fanconi's anemia.
In this particular deletion. So that's what you need to tell her, isn't it? She's facing a pregnancy. Now, how would you speak to her regarding the pattern? All those are.
So one, in this type of deletion, there is chances of skeletal abnormalities, which she is having short stature. Other than that, she doesn't have anything. There's chances of solid organ tumors are also more. So when we are these aplastic anemias, especially in pregnant ladies, they are ideal candidates for hematopoietic stem cell transplant. So when usually we try to prime them with this immunosuppressants. So when we use immunosuppressants, we should be a little cautious so that we don't trigger new malignancy. Already they are more prone for solid organ tumor.
Sure. Yeah, but she is not thinking about a BMT and all in front of you, isn't it? She is.
She's delivered, sir. 2 weeks back, she's delivered.
Okay. Are you talking to her now about the BMT?
No, we have called up for OMC visits, sir.
Okay. Okay.
And this thing has a chance of diabetes also. She's labeled as gestational diabetes mellitus, but we don't know whether it is only gestational diabetes, because most of the Indian pregnant ladies, they come to the hospital first when they're pregnant. So, yeah.
So what would you tell her about the baby? That would be definitely one of her main concerns, isn't it?
Yeah, there is this, because it is autosomal recessive pattern, the baby has a chance of getting the disease, and other family members should also be screened, like her brothers, sisters, and all also have to be screened. And
no. For the baby's thing, how do you?
So babies, it depends depending on the treatment, whatever we are giving.
No. Have you thought through that and spoken to her about that? Yeah. That might be something that would be running through her mind, isn't it?
One, during the delivery, she can have chances of having spontaneous abortion, then preterm delivery, and during labor, this complication.
She has delivered.
Yeah, she has delivered. Yeah. And post-delivery also, if he transfers a lot of blood products to her, so there is chance of transient thrombocytopenia in the neonate, which is like born, and even the baby is having some chances of getting this disease. So usually they present in childhood, and they can also push up to the adulthood of 17 to 40 years of age. So inheritance pattern can be autosomal recessive or X-linked recessive. Extra hematopoietic abnormalities like skeletal abnormalities, genitourinary tract abnormalities, kidney abnormalities can be present in Fanconi's anemia. Bone marrow failure in Fanconi's anemia is 90%, and short telomerase chromosomal instability, which can be present here. And genes identified, there are 22 types of genes which is identified with this Fanconi's anemia. And the treatment is, if this is for the general population, if it is based on the age, if they are less than 40 years, more than 40 years, less than 40 years, if they have a actually identical donor, then they can go with the hematopoietic stem cell transplant. If they don't have a donor, then they have to be in this antithymocyte globulin and cyclosporin L-thrombopite can be given, and they can be primed, and they can find out the matched unrelated donor. If they don't have, then they can go with alternate donors as well. This is with general population, but when it comes to aplastic anemia in pregnancy, it is just the supportive care. This is to maintain the platelet count about 20,000 with platelet transfusion, and cyclosporin is safe in pregnancy. It is only given in the very severe type of aplastic anemia. So we conducted MDT for this patient. We set the target value for, this is not in the general guidelines. This is just there in few articles. General guidance American College of OG and Royal College of Obstetrics and Gynecology, they don't mention this. So we cannot just emphasize this into all the patients. So we had to conduct MDT. So in MDT, we had set the target value of 20,000, hemoglobin of 8% throughout the pregnancy. And at the time of delivery, platelet is the target was set to 50,000. Plan of delivery was at 37 weeks, and Tranexa could be used during any bleeding manifestation was there, and transplant to decide after delivery. So pregnancy.
Maybe we should wind up. I think it's a fantastic presentation, but just that we are spilling over time. Is there something you would really like them to know?
So, yeah. The thing is, most of the people outside, when platelet is 20,000, HB is 8, sorry, platelet is less and less than 1 lakh or less than 50,000, they become very anxious and they start treating with multiple transfusions and beat RBC, beat platelets. I want to show this thing. And this is from Manipal, KMC Manipal. Yeah. See, most of the supportive treatment of aplastic anemia is related to pregnancy transmission of blood products. But this itself can cause HLA alloimmunization. Platelet transfusion refractoriness can also be possible. But HLA matched HPA compatible platelet transfusion is not feasible in Indian setup because it is going to be very costly business. And that is why we have to make sure you don't transfuse much. Keep the cutoff 20,000. When the patient is near delivery, LSCS is there, okay, 50,000, it's fine. And if anesthetist is agreeing, because even they don't have a proper like cutoff value of platelets, etc., during the OT time. So if they agree with 50,000, it is well and good. Try to avoid transfusion as much as possible because they are the ideal candidates for hematopoietic stem cell transplant. If we push them a lot of bloods and they are going to blood, then they're going to this HLA matching will be a problem. So it is managed conservatively in most of the articles which is found, and some places they have given anti-thymocyte globulin, they have terminated the pregnancy. In some places they have even steroids. Here we managed without steroids. Only once she got admitted in between, one Paxil was given because her HP dropped to 7.2, and yeah, that's it. During delivery, we definitely transfused platelets. That was 4 packs we had transfused. After that, now she's fine. Baby is also fine. Baby has no thrombocytopenia, and we have to monitor the baby and consult.
Any thoughts, anyone?
The problem with the treatment is there is no proper guidelines. Hardly in this from 1975 to 2020, hardly only 52 cases have been reported in PubMed. This is this collective article regarding that.
Yeah, it's very good that you managed it well, and she had a.
We had other two more cases also. So we have they are also
Sure.
We are managing it.
Very good. Just to get a context, can you tell me the years of training each of you presented are in? So Osborne is which year? Is the first year, and Divya Mary, first year, and Rajesh Kannan, first year, and Ramya,
Postdoctoral fellows.
Okay, so of course you very good presentations, but I think the surprise, isn't it? Yeah, so fantastic, very clear clarity, and I really liked it.